Okay, right. Thank you very much, everybody. So next we have Dr. Tseng. So he has been practicing for over 20 years. He is a surgical oncologist and a leader specializing in retroperitoneal LMS at the City of Hope Hospital. So having extensive experience in Chicago, San Francisco, Texas, LA, and now the City of Hope, he is a leader in his field, and his interest specifically in retroperitoneal sarcoma, which includes the abdomen, retroperitoneum, extremities, trunk, have led him to be a top researcher. In fact, LMSDR, as Sharon had highlighted last night, have funded a grant for Dr. Tseng. And hopefully he'll give us a little bit more insight into that today, as well as his other work in our LMS. So without further ado, we'd like to welcome Dr. Tseng.
Great. Well, thank you for that introduction. It's a pleasure to be here. I know it's getting close to lunchtime, so I'll try to stay on time. So I have the pleasure of speaking to all of you about a specific subgroup of leiomyosarcoma, which is tumors that occur in the retroperitoneum. And as was mentioned, I'm a surgical oncologist at the City of Hope. So we'll get started. So my disclosures, I am one of the panel members for the NCCN with soft tissue sarcoma, and also I contribute to the up-to-date retroperitoneal sarcoma section. Just as another disclosure, I am a surgeon, as mentioned, so I will be talking about other therapies besides surgery, so radiation therapy, systemic therapy, just in a more superficial sense. But for details in terms of the therapies, for example, for systemic therapy, I would defer to the medical oncologist. Brief outline of my talk. We'll begin with a little bit of a background to get everybody on the same page, and I realize that there's a diversity of knowledge about the disease, about sarcoma, about leiomyosarcoma. Then we'll talk about distant metastasis, multimodality treatment, and finally how we can optimize management. And that's where I'll talk a little bit about some of the research that I'm doing in retroperitoneal leiomyosarcoma. And throughout my slides, I do put these italics just because just for some of you who are not familiar with some of the medical terms, I thought it would be easier to know, for example, that distant metastasis means spread to other organs. And I apologize for those of you who already know that, just to make it, to get everybody on the same page. First of all, background, soft tissue sarcomas. And whenever I talk about sarcomas, I do emphasize that it's plural, it's soft tissue sarcomas. There are 1% of all cancers in adults. There's at least 70, probably 100 different subtypes that are recognized by the WHO. I like to compare this to when I see patients in clinic, and when I talk about sarcoma, I like to say that it is a little bit like wine. Now, the disclosure to that is I don't drink wine myself, or at least I'm not a wine connoisseur, so when I wrote this editorial, I had to get some advice from friends and colleagues who know how to describe wine. But the idea is that there are many different types, there are many different nuances that are important to recognize. So, for example, liposarcoma is one of the major subtypes of sarcoma, and of course there's leiomyosarcoma, which we're all very interested in, of course. Again, this is just background, but leiomyosarcoma is soft tissue sarcoma that arises in the smooth muscle. For those of you who aren't familiar with what that is different from skeletal muscle. So it's a type of muscle that typically lines, could be blood vessels, it could be organs such as the uterus, causes contraction just like muscle, but it's different from the typical skeletal muscle that you think of with your biceps or with your legs. This is what the tissue, leiomyosarcoma tissue, the actual tumor tissue looks like under the microscope. And these are some of the tissue markers that the pathologists use to identify that a particular sarcoma is a leiomyosarcoma, different from, say, a liposarcoma or other type of sarcoma. And then the way what I like to tell patients in clinic is that tissue markers are kind of like the clothing that you wear. So it helps us to identify, for example, a police officer wears a uniform or a doctor wears a white lab coat. These are the surface markers on the tissue, on the cells, that say that this is leiomyosarcoma and not angiosarcoma or liposarcoma. You can also look at the genetics of the tumors, but unfortunately, as was probably discussed in some of the other talks, there are no specific translocations for leiomyosarcoma, which also means that translocations really mean big genetic changes, but it also means that there are no mutations that can be readily targeted for leiomyosarcoma currently. But we're hoping through research we can identify novel targets that we can target. And then, again, for background, and I think this is important to recognize, and this is why I'm talking about retroperitoneal leiomyosarcoma today, is that leiomyosarcoma, the cancer of the smooth muscle, is a very heterogeneous disease. And while many of you, I'm sure, are familiar with uterine leiomyosarcoma, there is leiomyosarcoma that occurs elsewhere in the body, that includes the limbs, or the extremities, the body wall, skin, and other rare locations. And then, of course, there's a retroperitoneum, which is the back of the abdomen. This also falls into a subset that some of us define as vascular leiomyosarcomas. And the important part of this is that each of these, the behavior and the prognosis, so behavior, how they respond to treatment, and the overall prognosis is very different depending on the location. So it's the same disease, it's still leiomyosarcoma, but if you have a skin leiomyosarcoma, as an example, that is almost readily curable with just a simple excision, whereas on the other end of the spectrum, same disease, leiomyosarcoma, retroperitoneal leiomyosarcoma, is very difficult to treat. And this is the retroperitoneum. It might take you a little while to say that a few times to pronounce that properly, but retroperitoneum, it basically means the back of the abdomen. And those are things like, where that location is where you have the kidneys, major blood vessels, the structures, the organs and structures that are shown here. Liposarcoma does make up the majority of retroperitoneal sarcomas, but importantly, there 10 to 20% are leiomyosarcomas. So retroperitoneal sarcomas make up about 10 to 15% of all sarcomas, and then within that 10 to 15% of all sarcomas, 10 to 20% are leiomyosarcomas. So it is very rare. It's rare to rare. And then importantly, and you'll see, I'll talk about this, I'll circle back to this in my other slides, there's inferior vena cava retroperitoneal. So inferior vena cava leiomyosarcoma, which is within the retroperitoneum. Surgery is the main form of treatment and the only chance for cure, multiple references for that. But the important point is to recognize that surgery for retroperitoneal sarcoma, and specifically retroperitoneal leiomyosarcoma, is very challenging. This is not my data per se, it's just a paper that I published showing the percentage of cases in green of complete resection, that means complete removal of the tumor, and then in red is the mortality meaning death from surgery. And you can see that early on there was actually a fair amount of mortality just from surgery, and it's only in the last probably 10 years or so where the mortality is acceptable. It's basically low, very low. But these are very challenging operations. This is a review paper. Happy to send this to you guys if you're interested. This is more in the medical literature, just about how to manage surgical management and the techniques of surgery, which I won't go into for this talk. This was also supported by the foundation, so I'm very grateful for that. And one of the key points is that besides the technique, so besides the technical difficulty of doing these operations for retroperitoneal leiomyosarcoma, it is important to understand the biology of the disease. So by that I mean the behavior, what we expect to happen even with complete removal of the tumor. So understanding the behavior of the tumor, the leiomyosarcoma, is just as important. In fact, that seesaw there, it seems like what I'm trying to hint at is that it may be even more important than the technical aspects of doing a good, perfect operation. And then if you're interested, there was this interesting article that someone wrote about how I prepare for these big operations. It's still online if you want to Google it. There is a little bit of improvisation, just not saying that I don't prepare for it, it's quite the opposite. It's saying that at the time of surgery, sometimes you see things that you don't expect based on the CT scan or the MRI. So these are, again, very challenging operations. This is an example. This is a 56-year-old male with retroperitoneal leiomyosarcoma. This is a CT scan, and in green, I circled the tumor. So these are cross-sections. When you're looking at these CT scans, this is like, imagine the patient's body on the CT scanner, and it's like a French baguette or a sausage, and you're making cuts into it. So this is just one slice, one cut. The tumor is there in green. These are this is a different view, but it's trying to point out important structures like the duodenum, like the inferior vena cava, for which this tumor is very intimately associated with it, involving it. This patient, here we go. So this patient underwent chemotherapy. Sorry, this is a little blocked out there. The patient underwent chemotherapy first, followed by surgery. And at the time of surgery, we had to remove part of the vena cava, the head of the pancreas, the duodenum. That's called the Whipple procedure. We had to remove the kidney. We had to remove the right colon. So that's quite literally 4 operations in one patient, and that's just to get the tumor out completely and in one piece, as shown there. This is another example. This is a subgroup of retroperitoneal leiomyosarcoma, which are tumors that develop from the vena cava. By the way, we call it inferior vena cava because superior vena cava is the one that's above the diaphragm going to the heart. So this is the abdomen. But why I wanted to show this one is because the white arrows there, that shows the types of reconstruction that a vascular surgeon has to do when we remove the vena cava. There's basically a synthetic tube. It's a graft is what it's called, but there's a synthetic tube that sits in the place of where that vena cava was previously when the tumor was there. So this is one of my key points for this whole lecture and this whole talk is that for retroperitoneal leiomyosarcoma, distant metastasis, again spread to other organs, is the predominant issue. It's the major issue. It's the major issue, and more so than leiomyosarcoma of the uterus and other parts of the body. This is the data that supports this is the data that we have for retroperitoneal sarcoma. So this is looking at, and this is multi-center. This is, I believe this paper was 8 centers, 1,007 patients with retroperitoneal sarcoma. The different curves there, the different colors are different types of sarcoma, liposarcoma, the different types of liposarcoma. And anyways, that first curve there is showing local recurrence, which means after surgery, what percentage of patients have the tumor return in the area of the prior surgery, local recurrence, so in the abdomen. And you can see LMS there in purple, it's about 10%, so it's still fairly low compared to liposarcoma, which we won't talk about. But after good, complete operation, even as challenging as it can be, we may have to remove multiple organs, structures. The chances of recurrence locally is very low. In fact, I often say that in 10 years of doing retroperitoneal I actually have never seen a local recurrence. And that's not to say that I'm the perfect surgeon, but it just fits with this data. The problem, though, is distant metastasis. And if you look at the same curve, which is in black, and the purple star right there, the risk of distant metastasis is 50% in 5 years. So that means in half of patients, by 5 years after surgery, and most of this is within the first 2 to 3 years, but half of patients will have distant metastasis. It'll show up in the lungs and the liver. It's very frustrating for all of us because we've taken a patient, the patient has undergone a major operation, long recovery for it, potentially long recovery, and then it's a 1 out of 2 chance that the disease is going to come back in other organs. This is a different series from a single institution from Memorial Sloan Kettering in New York, 675 patients, but same idea, that local recurrence is fairly low and distant recurrence is high. You can see that among all the different types of retroperitoneal sarcoma, leiomyosarcoma is at the very top of distant metastasis. So that's why it's important in retroperitoneal leiomyosarcoma to think about, to consider, to implement multimodality treatment. And multimodality treatment means, what it really means, I wrote there more than just surgery, but what it really means is it incorporates not just surgery, but potentially radiation therapy, potentially chemotherapy or other drug therapies. And when you look at, so when you talk about multimodality therapy, about doing more than just surgery, one of the resources that we can turn to, and I encourage all of you, if you're interested, to look at this. This is the NCCN, which is National Comprehensive Cancer Network. And what that is it's all of the major cancer centers around the United States. This is United States national. But it is all the representatives from each of the cancer centers around the country that get together every year to revise and update the guidelines for how to take care of all the cancers. And there is a subsection of soft tissue sarcoma. And again, I'm part of that panel last year and this year. And so when you look at these guidelines for multimodality treatment, there is of course a section for retroperitoneal sarcoma. And I don't want you guys to pay too much attention to this in terms of the details. There's a lot of details, and I purposely blocked out some of the irrelevant details so you don't get lost in all the words. But for patients that have resectable disease, so that is disease that, oh, by the way, I just wanted to mention that the reason why all of these are kind of more in medical terms is because the NCCN guidelines are what, outside of major cancer centers, academic centers, community hospitals, non-academic, non-cancer centers, they usually turn to this as their guideline to how to manage leiomyosarcoma, for example. So that's why this is geared towards physicians, and it's geared towards physicians that don't usually take care of this disease. So that's why it's an important resource that many of possibly your first physicians that you see will probably go to NCCN guidelines first to help guide them in terms of how to manage the disease. So anyways, getting back to this, so resectable disease means tumor that can be removed, and if you have a resectable disease, it's a tumor that can be removed by surgery for retroperitoneal sarcoma, the NCCN guidelines do say that you should consider neoadjuvant therapy. And neoadjuvant therapy means therapy that's done before surgery. Specifically, that's referring to radiation therapy or systemic therapy. They leave it kind of vague, we leave it kind of vague, just saying to consider, because it very much is individual decision that your physician, your team makes with you. So very personalized, very individual decision. But definitely consider neoadjuvant therapy. And then after surgery, for retroperitoneal sarcoma, not to do radiation therapy, but to consider adjuvant systemic therapy. So you can see for retroperitoneal sarcomas, including leiomyosarcoma, NCCN guidelines recognizes that it is important to strongly consider systemic therapy, drug therapy, chemotherapy, either before or after surgery. Now, beyond NCCN guidelines, I wanted to introduce you guys to, there is significant, there's a huge effort that I'm also part of, which is international collaboration. And this is international collaboration specifically for retroperitoneal sarcoma. We have our annual sarcoma meeting coming up next week, and we as part of this meeting, there's a sub-meeting that is this working group. And this working group is, again, dedicated just to retroperitoneal sarcoma. It's very much international, so it goes beyond the NCCN, which is just the United States. Most of the representatives, most of the people on this are from Europe, as well as the United States, but there are some people from Asia as well. And why I bring this up is because a lot of our research in the field for retroperitoneal sarcoma, and including leiomyosarcoma, comes from this international collaboration, this working group. So when we talk about multimodality therapy, some of the data from the working group, we call it the TARPSWIG, or I just call it the working group. But from that international working group, we have data about radiation therapy in retroperitoneal sarcoma. That's called the STRASS trial, STRASS. It's an abbreviation, of course. But the STRASS trial was published in 2020, and this is looking at the role, the utility, of trying to study the utility of neoadjuvant radiation therapy. So again, that means you give patients radiation therapy before surgery, and what is the benefit of that compared to patients that only receive surgery without radiation. And the short answer, and this is the sub-analysis for the leiomyosarcoma patients, the short answer is that there appears to be no benefit for neoadjuvant radiation therapy in general, possible benefit in liposarcoma, but no benefit in leiomyosarcoma. So this is the best, this is a clinical trial, this is a phase 3 trial, it was randomized, prospective, and so with this data, this is the best data that we have in the field. A lot of us are going away from doing any radiation in leiomyosarcoma, retroperitoneal leiomyosarcoma. And then the other part to this, which is sometimes talked about, sometimes not talked about, is increased surgical complications with neoadjuvant radiation therapy. This is a little controversial, depends on which surgeon you ask. If you ask this surgeon here, I would say that I agree with this. I do think that it's harder to operate on a patient who has had radiation therapy because the tissues are, I don't want to say damaged, but I just said it, the tissues are damaged by radiation, so they're harder to work with. They're either more vascularized, more bloody, or it's fibrotic, which is very stiff. So I personally don't like radiation therapy. But the data from this study, this phase 3 study, STRASS, does seem to suggest that. Now this actually was not statistically significant, but you can see the column on the far right-hand side, patients that received radiation therapy before surgery, preoperative radiation therapy, the frequency of complications, the frequency of blood transfusions required was higher by about 10%. Compared to the patients that did not receive radiation, just had surgery. Now, the systemic therapy. There is the STRASS, so that was STRASS 1, or we just say STRASS, but STRASS 2 is the study that is looking, and it's an ongoing study, so we don't have data for this, this is looking at, instead of radiation therapy, it's looking at the benefit of doing systemic therapy, specifically chemotherapy for retroperitoneal sarcoma. This is the basic layout of the randomization in the study. And you can see that it's only for high-risk retroperitoneal sarcoma. So leiomyosarcoma is considered high risk. High risk is referring to the chance of distant metastasis. Remember we said earlier it's up to 50 to 60%, depending on which study. Eligibility is leiomyosarcoma, retroperitoneal leiomyosarcoma is definitely one of the major groups that's being studied with this, with the STRASS-2 study. And so again, it's an ongoing study. This is open at City of Hope if anybody is interested in finding out more details about it. So one question, ultimately the question with the STRASS-2 study is how effective is systemic therapy, and specifically for retroperitoneal leiomyosarcoma. This was something that I had, through our international working group, I had a chance to study this in a retrospective fashion. So not a clinical trial, just looking at 13, in this particular study was 13 different centers around the world. And we looked at basically, we studied a lot of things with this. We studied, one of the things was how often do the tumors respond? How do they shrink? How often do they shrink when you give chemotherapy before surgery? And you can see for the LMS group, the answer is about 24%. So about 25% of patients will have some shrinkage of the tumor with chemotherapy that you can see on the CT scan before surgery.
What about radiation?
This was not studying radiation.
Okay,
Yeah.
thank you.
Yeah. So it is, and that is a fair amount, but I also want to say that it doesn't mean that the tumor goes away. And to have a partial response, it basically means it's a 30% shrinkage. So when we say that patient had a PR, a partial response, it's 30% decrease in the size of the tumor. But the regimen also is very important. And that's something that, I think the medical oncologists have talked about that, or we'll talk about that. But the appropriate drug selection, the appropriate chemotherapy, if it comes down to targeted therapy or hopefully someday immunotherapy for leiomyosarcoma, it's very important to recognize that it is leiomyosarcoma, not liposarcoma, and to treat it appropriately. So when patients received adriamycin dacarbazine in this study, you could see the partial response rate was much higher than if they received any other regimen. So last few slides, I wanted to talk about how we can optimize the management of retroperitoneal leiomyosarcoma. So surgeries are very challenging, big operations, and we know that the natural disease biology, the natural behavior of the disease is at a high risk of distant metastasis, spread to other organs. So how can we improve on managing patients that have this? And then I think a very important question, and this is a question that I'm trying to answer through support from the foundation here, is how can we predict metastasis? And this was a study that, through support of the foundation, we were able to publish. This is a clinical study. And this was in collaboration with the sarcoma group in Milan. I have close collaboration with them, close ties with them, and I frequently go to Milan, and we exchange ideas and work together. And this was a paper that was just published a couple of months ago, in which we studied predictors. We tried to look for predictors of distant metastasis in retroperitoneal leiomyosarcoma. And what we found is at the top there. So we found that tumor size and grade are predictive of distant metastasis. DF is distant metastasis in that curve. You can see tumors that are large versus small, 10 centimeters is the cutoff for that. The larger tumors have a higher risk of distant metastasis. Higher grade tumors, grade refers to how aggressive the cells look under the microscope. Higher grade tumors have higher risk of distant metastasis. Now, those two, this is not that surprising. I mean, it's pretty intuitive that larger tumors or more aggressive looking tumors are more prone or have a higher risk of spread. So what we found is when we went through the data together, and specifically when we looked at all the pathology specimens, all the tumors that have been removed, and we looked at the relationship of the tumor to the vena cava, that's in blue there, schematically, the extent of involvement of that vena cava was predictive. And before I show you that, data is here. But, so we came up with a classification. We went through all the patients that had resection, had the tumor specimen, went through with pathology, also intraoperative photographs, radiology as well, and we came up with this classification scheme of type 0, type 1, and type 2. And I always thought it was kind of surprising that you can have a very large tumor that can be just sitting up against the vena cava, just right next to it, like type 0 right there. It's not actually involving it, it's not actually going through, it's just bystander on the outside. And it does make sense biologically because the cell that it probably originates from, remember it's a smooth muscle cell, is coming from the wall of the blood vessel. So it's not the inside of the blood vessel, it's more the wall of the blood vessel. So that means that the tumor is going out away from the lumen or the center of the blood vessel. But sometimes you do see this type 1 where you have this interesting kind of polypoid, that's a rounded surface on the photograph on the bottom. You have this rounded protrusion, it's a smooth protrusion inside the blood vessel. That's type 1. And then type 2, you have just frank invasion of the blood vessel. And sometimes you can see clot in the blood vessel. That's the dark, the blood clot, the dark coloration, the picture on the bottom there. So we came up with this classification scheme, and then it was in fact predictive of distant metastasis. The more invasive it is, the more predictive of metastasis. But what's also interesting is that when you have patients that have type 1, which is just this polypoid smooth invasion, that doesn't seem to make a difference. The outcomes for distant metastasis are about the same as if you didn't have any invasion. So then we get to so that previous study was more of a clinical study, so one of the research projects that's being supported by the foundation is looking at immune biomarkers for metastatic disease, and specifically looking at how we can predict which patients will have metastasis and which will not. This also gets to the mechanism of disease. So the project workflow for this is to look at, to start off taking all patients with retroperitoneal leiomyosarcoma and to separate them up front, going back retrospectively to say they've had surgery, did the patient have metastasis, which is M1 here in this diagram, versus they did not have metastasis. And then, and we would undergo exclusion criteria, and then to retrieve the slides and basically to look at the gene expression of the tissue. And that means actually taking the original tissue from surgery to study at the time of surgery before they underwent metastasis. Was there, are there specific genes that are more commonly expressed that would predict metastasis? Because we would know that the patient, already metastasized. And the whole idea of this is to compare the two groups and then to look for immune biomarkers. So this project is ongoing, and I don't have data to show you right now. That I don't have one target to say that's where we're going with this project, and we're actually expanding to involve collaboration with Milan, and specifically it's because of that paper that we had published, the clinical study that we did, because in this clinical study we did also study extremes of outcomes. So we had patients that had very good outcomes, and very good outcomes means no metastasis for more than 5 years. And we had patients that had unfortunately, very rapid metastasis within less than a year, I believe, in this study. Within less than a year, they already had metastasis. So we have a great subset of patients that we were able to carry out this study and really hopefully be able to find some immune biomarker that can predict metastasis. So that's coming towards the end of my slides. Summary, just a few more slides, but in summary, retroperitoneal leiomyosarcoma is different. I would argue that it's different from leiomyosarcoma in other locations. Same disease, but just based on location in the retroperitoneum compared to other parts of the body. The behavior and the overall prognosis is unfortunately much worse. The main treatment is still surgery. We talked about how challenging that can be. And distant metastasis is the predominant issue, 50 to 60% of patients. Multimodality therapy, multimodality treatment is key, and it's less so radiation therapy, as we're finding in the field, and more so with systemic therapy. Now, the data that I showed is mostly chemotherapy, so I'm always grateful for medical colleagues like Dr. Chow, Dr. Chemlowski, Dr. Dolnick that you'll hear this afternoon, because there are other drug therapies besides chemotherapy that are being explored and that would hopefully be able to move the needle, so to speak, in terms of a treatment of this disease. We certainly need it. And lastly, we talked about STRAS-2 and some of the research that's going on, including some of the work that I'm doing, looking at predictors and ultimately mechanisms of metastasis. And lastly, I just want to say that it's important, I didn't emphasize this, but I want to emphasize that it's important to have a team effort, not just surgery, but chemotherapy, or not just surgeons, but medical oncologists, radiation oncologists, as a group discussion of each individual case. Ideally, all those members of the discussion should be sarcoma specialists. And then finally, just to maintain hope. It's a difficult disease, whether it's retroperitoneal or not retroperitoneal. But I'm so glad to see everyone here. It's such a wonderful to see such a huge turnout, and to keep hope when you're fighting with this disease. Thank you, and there's my contact information. I also have an Instagram page if you guys are on Instagram, feel free to follow that. Thank you for your time.
All right. Thank you very much, Dr. Tseng. So again, we got some questions from yesterday as well. So one question that I had specifically was, so you highlighted neoadjuvant multimodality treatments. What about adjuvantly? So after surgery, what does that mean?
Yeah, it's a great question. We don't have, most of our data is in the neoadjuvant setting, so we don't really have a good comparison for neoadjuvant versus adjuvant being after surgery. The one consideration, at least from a surgical standpoint, is that these big operations that unfortunately patients have to undergo sometimes, that can lead to a delay in receiving adjuvant therapy. Because it could take realistically 2 to 3 months, sometimes longer than that, for a patient to fully recover to the point where they would receive the same therapy after surgery. And so we tend to favor giving, from a surgical standpoint, we tend to favor giving the drug therapy, the systemic therapy, let's say, before surgery, because then you could get it in to the patient, but also be able to see the response to the therapy. You can see the tumor shrinking or not shrinking. Sometimes, unfortunately, the tumors grow on neoadjuvant therapy as well, which is, it's bad, of course, but it does actually give us some insight into the biology of the disease that it's particularly bad. So we tend to favor neoadjuvant.
Thank you. So they were asking about genetic testing, tissue testing. So are there genetic differences between our LMS and ULMS? And actually, are there any genetic biomarkers in our LMS that can be used for targeted therapy?
Currently, unfortunately, no. We don't have great markers to distinguish them. The uterine leiomyosarcomas can have estrogen and hormone receptor positivity, but less so with retroperitoneal. But it's not it's not something we really actively target.
Are there any questions from the room? Oh, okay.
So good, no question.
It's less of a question, but Julie underwent the same surgery you described, and she does have the metastasis. So you have one person in the room that had the IVC reconstruction.
At least.
There's more.
I think there's actually quite a few in here who've had the IVC.
Raise the flag.
Were there some other questions? All right, okay, here we go.
This is for all the doctors, because you've all touched upon it, but I have metastatic cancer. And how does one look at all these clinical trials, which are so confusing, and how do we know which one would be the best one to participate given our specific situation, since leiomyosarcoma has so many subtypes? Because we obviously want the one that would be the most, have the most positive outcome for our given situation and the where we are in our disease and the exact type we have.
Thank you, Anna. I'll just bring the mic back.
Thank you for that question. Sometimes I defer to the medical oncologist. They can answer that in a different way. But if you were to ask me, my opinion, I think because there's no specific marker for leiomyosarcoma, no specific target at this point, if I were to give advice, I would look for clinical trials that specifically focus on leiomyosarcoma, or that at least recognize leiomyosarcoma, not just all cancers. So more of a histology-specific trials that are available. That's what I would look for.
Okay, kind of the same thing with the metastasis already. If we already have distance, what's the difference between the LMS and the uterine LMS and the retroperitoneal LMS once it's metastasized? Like, are there different treatments at that point?
It's a great question. As far as that's more of a medical oncology type of question, but as far as I know, I don't think there are major differences once it's metastasized. Certainly Dr. Chadwick and others can chime in. One thing I did want to say about metastases, and I didn't talk about this in the lecture, but leiomyosarcoma is one of the histologic types of sarcoma where often we do metastasectomies. So we do combine surgery with systemic therapy, occasionally radiation therapy as well, even when it's spread. So sometimes it's a very select patients. It's not all patients, but in certain patients, say that have one lung metastasis or 2 or 3, not a lot of them. We sometimes have thoracic surgery to remove those lung metastases, and you can actually render a patient disease-free with a good combination of medical oncology, surgical oncology, and occasionally radiation therapy. I've seen that in my own practice. Some of the patients that we share, where it's a combination, truly multimodality therapy, even in the setting of metastatic disease. And the patient is still alive for many years beyond what we would have expected. So that's another example, not to lose hope in that situation.
Thank you, Dr. Tseng. I think Dr. Chawla had.
Yeah, I'd like to answer your question. So, leiomyosarcoma itself, as you know, is rare. Where it originates does not matter. But once it originates, we need to do the first defense, and the best defense is surgery. So if in the extremities, easily you could remove. But sometimes, and even in past, we used to resort to amputation if you can't save the life. Uterus, we do hysterectomy. Retroperitoneal liposarcoma, we do extensive surgery. It may originate in inferior vena cava where we may have to do the surgery. But beyond that, once he escapes site of metastasis, it depends where it escapes. First site is either local or lung, and then the treatment is systemic treatment first, which again the standard chemotherapy, investigational chemotherapy, and targeted therapy. Targeted therapy is mainly still in a small portion of patients where a specific marker expresses. Immunotherapy again limited, but we use all three modalities. Then other local treatments, whether we do surgery, we do RF ablation, cryoablation, PEF ablation, or intralesional into the tumor we inject chemotherapy, immunotherapy, or targeted therapy, or oncolytic virus therapy. So all these approaches depending on the site, but where it originated, it's like a mad dog or criminal dog in our body. Doesn't matter what kind, where it is, we have to control.
Okay, so I think we've probably only got time for one more question.
I just also want to make a comment, I don't know if it's relevant, but also uterine leiomyosarcoma, sometimes we see, for sure it's called morcellation, where the tumor is broken up into pieces before it's taken out, and the disease is, it's not the right thing to do, it's the absolute wrong thing to do, but we see the disease throughout the abdomen. And that's also a different situation. That's not something that I was specifically referring to with this talk, or but that's a kind of a different situation.
I think we just have. Okay.
So all of your patients' family, even when they say it's a stage 4, lung mets, average survival is 1 or 2 years, as I said before. Again, that's an average. That does not mean you in particular. It's unique situation. If we control the disease by systemic therapy and we resect the tumor, even if it is an abdomen, and Dr. Tseng resects, or in the lung limited disease we resect, you can still cure about 30% of those patients completely. That means somehow we got rid of those micrometastases, immune system goes away. And somebody even came today to me and said, oh, she went to the doctor and said, your survival is 3 to 6 months. And she's still doing well, getting some other treatment. It means 3 to 6 months, what the doctor said was not that she was completely pessimist. Yes, it was wrong to say, but that clarification is an average person. If we take 100, majority of them will only survive, but that does not apply to particular person if we use all the modalities.
So I think we really have to go to lunch very, very, very soon, because I believe it's outside already, but you've patiently waited.
Sure. This is a quickie. About how many chemos, if surgery is indicated, about how many chemotherapies would you want to have, cycles would you want someone to have prior to their surgery?
It depends on the medical oncologist. It's a discussion that we have with medical oncology. It also depends on the tumor response. Because unfortunately sometimes the tumors also progress during therapy, and then with discussion with medical oncology we may switch to a different therapy to try to get it under better control. But generally speaking, 2 to 3 cycles kind of gives us an idea based on the CT scan, how the tumor is doing, whether the patient's ready for surgery. So
the very last question is if you had a pot of money, what would want to do with that money.
Well, I think I'm a little biased towards retroperitoneal sarcoma and leiomyosarcoma, but I think if we could create a tissue repository specifically for retroperitoneal leiomyosarcoma, and through the working group that I'm a part of, there's a lot of discussion about doing that. There's a lot of logistical issues that kind of a lot of red tape, but a tissue repository that could be readily accessed by anybody, meaning any center, whether it's in the U.S., whether it's in Europe, but just kind of a centralized repository of tissue, also with clinical information too on how the patients did.
Thank you very much once again, Dr. Tseng. So we only just learned today that you don't like wine. However, perhaps you can give it to one of your loved ones and just also give our appreciation. So thank you very much. So we do have lunch now, and we have invited our doctors to join us over lunch. So if you do have some further questions, please don't hesitate to ask. So we are due to meet back here at 1:15. That gives us 35 minutes for lunch. So we'll see how we're getting on. We'll aim for 1:15, but if we need more time, then we will indicate that. Thank you once again.
Question. Reporter.
I returned my $100
Gosh, I'm glad you said that. I gotta turn it off. And I never can figure out how to turn it off.